So hi everyone, thank you so much for Collective Minds Radiology for having me back. I assume that you can all hear me. I'm not wearing my shirt and tie like I usually do because I'm working from home today. So I think what is really fun actually is that obviously you got courses on how to go through cases, and I'm not running a course. I do run courses with Radiology Seminars where it's kind of a bit more, we go through a very specific system-based way of looking at things. This is more a bit of fun going through some cases, and if you're anything like me, hopefully you just enjoy going through cases live and things like that. So hopefully you can access the cases. They should be in the chat. If not, Saad, would you mind just putting it in the chat for everyone so they can click and go through the cases at the same time as me? So I've got the chat function open as well. So, feel free to ask questions. I'm kind of trying to be as informal as possible. So hopefully, yeah, so that link is there now. So let me just do one thing before we begin. I like to keep a timer on just so that I know that I'm not overrunning. Just have a look, just make sure that everyone can see the cases. Can just say yes or no if you can see the cases. Okay. No one's speaking just yet. That's fine, no problems. So what I'll do, hopefully everyone can see my screen. I'm sharing my screen right now. And excellent, we've got a few. Yeah, so you do need a login. If you haven't got login yet, we might need you to ask you to sign up, and then we'll be able to maybe get you log in imminently. We'll see.
Everyone should have an account already, and they should be able to log in.
Okay, I mean, maybe do a password reset or something like that. Yeah. Just see if you can manage it. But look, don't worry. If you can't, as long as you can see my screen, we'll work through things together, and hopefully you learn things. And then you can always, because what's really cool is that we've got the videos on YouTube as well. And so, I mean, thankfully, we've had quite a lot of views for the last one, but they link the cases, so you could technically come back to it if you want to. So case number one here, we're just going to have a quick look. So first of all, we've got a plain film radiograph, and let's just say they fell over, hurt their hand, something like that. And we're having a look at this particular hand X-ray. And obviously, like I said with the last one, if you do see anything abnormal, please go for it and tell me what you think you can see. But otherwise, I'm just going to work my way through. So let's make this one the main screen. And what I'm going to do is just use the zoom function and just zoom in and just show you how I would approach going through this. So I've seen a few places where they would say something like, look at the soft tissue swelling first, which is fine. Yes, you can do that. But in reality, nowadays, I started doing that when I first began. But nowadays, I really go for the big money areas, right? Or the high yield areas is what I like to try and say. And so what you find is that when people fall over, obviously you've got let's see if I can get the pen function. You do have the kind of fractures that you get within these regions over here, within the sort of distal radius. That's one area you can get fractures. The other area you can get is a fracture located within the ulnar styloid as well. So that's a very, very common area to get fractures. And then when you're looking at fractures of the wrist or the hand, you want to make sure to see whether there's any sort of articular surface involvement. Very, very important. Sometimes you get fragments of bone sitting around here. Those are things to notice, because obviously if you've got fragments of bone and the patient tries to get the hand fixed, that little fragment of bone can actually impede a lot of the movement of the wrist. And the next high yield area, I would always say, is the base of the fifth or around the fifth metacarpal metatarsal. And it's quite interesting. I've said this in the last talk actually, but what ends up happening when people punch things, they don't quite punch it properly. I'm not saying you should go and learn how to punch people, but if you punch someone or punch something, then usually a lot of the time what will happen is that people aren't punching with the first two knuckles. They're going to be punching with these two knuckles, and the translation of forces isn't great. When you've got a punch like that, you want to be going down this way into the radial area. A lot of translation of forces, you can handle that. But when you go sort of like this, but you're punching this way, then you get the sort of abnormal translation of force and get fractures within this area over here. In this particular situation, when I've zoomed in, I haven't seen anything grossly abnormal located within the base of fifth. The next place you want to look at is the base of fourth. And again, that looks really kind of quite normal actually. But what I'd like you to do is when you do this in real life, make sure that you really do draw around every single bone, right? So you want to really, really draw around like so, like so, like so, like so, like so, and all the way around, just to make sure, because you have to remember you get a whole load of overlap, right? And sometimes people, oh, there's a fracture there. And then they don't realize actually it's just if you continue the bone like so, it goes like this, like this, like this. And actually there's no fracture there whatsoever. But the good thing is that if there was a fracture there, like a little bit of a fracture there or a fracture there, then you'll see that because you've taken the time to concentrate on a high yield area, which is the base of the fourth and the fifth, and you've had a look at the overlap of the bone to make sure there's no evidence of any fractures there whatsoever. And then there was a topic I spoke about last time, is the light of day sign. You want to make sure there's nice joint space going all the way along like so. And you can see that it's as if like you had a light and you're shining through my hand. You can actually see the light going through this little area over here, the carpometacarpal joints. And as long as you can see that and it's pretty much equidistant all the way, then you're not looking at a fracture, dislocation, or anything like that. But then, someone has pointed out that actually, hang on, that base of fifth doesn't look quite right. I mean, the first carpometacarpal joint on the hand, and you can really see the sort of wispiness, can't you? Like this kind of wispy white areas all over here. You can see it kind of looks a little bit more dense as you come closer to the joint line, and you can see there's a bit of loss of joint space within that region over there, right? So yeah, someone's right that you actually got what looks like first carpometacarpal joint osteoarthritis, and it's a very, very common place to get osteoarthritis. And I assume it's because, we're kind of, these days, we're always on our phone, we're tapping away, tweeting away. And those of you that follow me on Twitter know that I'm no stranger to a bit of social media fun. And so all of that tweeting and all that interaction is going to end up resulting in a little bit of osteoarthritis located within that region over there. So well done to whoever picked it up. And so you got to also look at the rest of the joints. And genuinely, I go through every single joint, all the way around, all the way around, all the way around to the very tips, go all the way around like this. Then I go to the next one, make sure they're okay, go to the next one. And hopefully you can see over here that this doesn't look quite aligned, does it? It looks kind of slightly off. So if I get the pen out again and draw a straight line like so, not a great line, but you can see it's slightly kind of veered off towards that side. You can see there's a bit of loss of joint space as well around that side. Oops, how do I get rid of that? I must have done a whiteboard by accident, or did I? Let's reset. Okay, so yeah, so you can see there's a loss of joint space, and there's a bit of sort of lateral medialization of the terminal interphalangeal joints, or the distal interphalangeal joints. Similar appearance over here as well. And yeah, you think to yourself, is it dislocated? Could it be dislocated? And that's why you'd actually want to look at another view. And so we've actually got a slightly oblique view here. And again, you can see a lot of the osteoarthritis going on within the base of thumb. If we zoom in, we just want to have a closer look over there. And to me, that doesn't look quite right. So you've got your trapezium and you've got your trapezium and your base of thumb. And to me, it doesn't look quite right. It looks like it's slightly slipped. And actually, when you look at the base over here, like this on this particular view, you can see a slightly jagged edge, and everything looks like it's slightly slipped out of the way. So in truth, in this situation, I'd be a little bit worried that there may actually be an underlying subluxation, or maybe even a dislocation of the first carpometacarpal joint. So if that's the dislocation you're talking about, I would actually say I'd be worried about that. Genuinely, I would be, because in the concept of trauma, and you've got that sort of incusclerosis and that malalignment of the trapezium with the thumb, then yeah, you'd be concerned about a subluxation. And if there's soft tissue swelling and it kind of tallies up with the clinical findings, then you'd be concerned that there could be a subluxation / dislocation of that first carpometacarpal joint. But over here, I wouldn't say they're dislocations. They're slightly laterally placed, and the lack of, and the loss of joint space, which you can also see in the middle finger, not so much on that ring finger, and not so much on the distal interphalangeal joint of the little finger. So when you've got increased sclerosis, loss of joint space in the interphalangeal joints of the distal interphalangeal joints, then you're more than likely looking at osteoarthritis. And this is quite a very important distinction to try and identify erosive changes versus osteoarthritis. So erosive osteoarthritis normally would affect the distal interphalangeal joints, right? Because we're kind of tapping away, we're keyboarding, we're tapping on the mouse and the screen, but the metacarpophalangeal joints, they don't usually have, you don't have that much osteoarthritis, right? But if you're having more proximal abnormalities, then you're probably looking at an inflammatory arthrosis. Now, with inflammatory arthrosis, which I will later I will go through that, we're kind of trying to go through things in stages, but you'd see no loss of joint space, and you may see erosive changes like big bites out of the metacarpal head. But in this situation, what we do actually have is what looks like very severe osteoarthritis to the distal interphalangeal joints. And we have severe osteoarthritis of the first carpometacarpal joint of the hand. And I'm a bit worried because that doesn't look quite aligned. It doesn't look like it's sitting in place in the region of the trapezium. Right, so hopefully there aren't any questions. I do have more hand x-rays coming up. So let's have a look. So well done for anyone that would have or did pick up the possible dislocation of the of the base of the fifth.